We're going to have Paul just share a few slides to explain what is Optum Labs, how did it get started, what's its mandate, how's it going to change the world?
Great, thanks, and good morning. Just want to give you a sense of what Optum Labs is about so that we can have a richer dialogue. And I'll begin by saying, and if you remember nothing else, the one sentence that you should walk away with is the first one. Optum Labs is an open, collaborative center for research and innovation for healthcare stakeholders interested in improving patient care. So it is in, as Colin already mentioned, Cambridge, Massachusetts. We're right across the river from the MGH and the rest of Boston, and we are serving a variety of communities. We're bringing together providers, academics, payers, pharma and life sciences organizations, the government, professional and consumer organizations, all of whom are interested in collaborating on health economics and outcomes data and comparative effectiveness data. I'm just adjusting the mic for a moment, apologies. And comparative effectiveness research. They're going to, some of them will be bringing data, some of them will be bringing expertise, others of them will be bringing technology, and we're all going to be working together with the interest of working on projects that improve patient care, lower the cost of improved care, and are transparent to the entire collaborative. And the idea is that these will be published, they'll lead to public policy improvements, and they will also generate clinical translation right back into the clinics where they can be measured and followed and improved, and that clinical translation can lead to national innovation in the delivery of healthcare. We're looking at systems-oriented comparative effectiveness, technique or device-oriented comparative effectiveness, drug-oriented comparative effectiveness, and even payment-oriented comparative effectiveness. And we're particularly interested in some specific aspects of behavioral and policy research, variations in care research, and heterogeneity of treatment responses. These are all, I'm sure, very important, and you're aware of the importance of those, and they are part of the ongoing research projects which have begun as well. And I want to stop and say that the most important thing about this is that we're building a partnership of organizations that are going to work together collaboratively at an equal level. However, this is founded by two very important partners, Optum and Mayo Clinic. And Mayo Clinic is our key partner. They're taking a major role in the administration and the governance and as well as the research in the center. So, and that's the reason why Mark Hayward and I are here together on this podium, because this really is an Optum and Mayo Clinic partnership that is very close. However, all of the other partners that will join in will again take an equal place in the round table of research. Very simply, we avoid a little bit the term big data, because big data has the implication of, in some people's minds, of a lot of unsupervised learning and identifying things without necessarily a specific direction for the analysis. But in fact, we are using a lot of machine learning techniques, and we're using a lot of data exploration techniques, which are indicated on the left in this slide, to identify and very rapidly cycle through research projects so that we can hone in on the research projects that we'll do with more traditional techniques of outcomes research and comparative effectiveness research. We're starting with 149 million lives of United Healthcare data, which is the largest administrative claims database that is supplemented with medications and lab results and others. We're putting on top of that the Mayo Clinic data, which is 5 million lives of electronic health record data, which is a very substantial amount of very rich electronic health record data, and 32 million lives at this point of data from Humedica, which also is very rich electronic health record data and overlaps about 15% with the administrative claims data. So not only is this data that is unique in its size, but it can be linked together directly, so you can follow the entire patient experience through the EHR and capture all the leakage, et cetera, that happens outside through the administrative claims data and get a richer answer. So I'm not going to go into this in detail, but I'll tell you the way that this works is we will accept applications from anybody who's doing this type of research, interested in improving patient care, lowering the cost of the delivery of care, and is willing to do it with complete transparency in a non-commercial fashion. Those researchers whose projects are reviewed and accepted and have a source of funding will get the data made available to them in a project sandbox, and they'll be able to work collaboratively. And we're doing everything to encourage not just take the data and go home, but take the data, establish a team of workers with synergy from the different types of institutions that are involved in Optum Labs, so that the collaboration will actually generate much more sophisticated and integrated looks at results, and generate more clinical translation and innovation than you would if it was just one researcher and one database. So that's an introduction to Optum Labs.
So let me get to the heart of the matter. What's in it for United Healthcare Group? And then similarly, what's in it for Mayo?
Sure. Well, so United Healthcare Group, I should just say, has two major components. One is United. It's United Health Group. Has two components. One is United Healthcare, which is a payer. The other is Optum, which is a services and technology company, which is very separate from United Healthcare, the insurer, even though we're both part of the same organization. Optum and United Health Group see this as a very important initiative because we believe that the opportunity to bring together all of these researchers to work together will identify new ways of looking at healthcare, new ways of delivering healthcare that will help improve the healthcare system overall, and will be indirectly a benefit for the way that healthcare is delivered through the Optum services and through the Optum providers, of which there are thousands that are owned or affiliated with Optum. But it's a rising tide that raises all boats. We believe that if the entire healthcare system benefits from this very public and very publication-oriented research and clinical translation, that being at the table and participating in it will advantage Optum just the way it will advantage any partner that participates.
So Mark, Mayo's one of the world's leading medical institutions. Why, with all of what happens already at Mayo, why did you guys need to do this?
Thanks, Colin. So Mayo does have a 150-year history of using medical information to study improvements in care and really being focused on continual improvement in the value of care we provide. We have hundreds, if not thousands, of teams around Mayo Clinic working to improve the care that we provide, improve outcomes, improve quality, while at the same time reducing cost and utilization. These are teams of health economists, health services researchers, epidemiologists, partnering with clinicians who are interested in, again, improving the care that we provide in a very scientific, methodological, kind of rigorous way. These teams often run into barriers where they know the hypothesis they want to test, or they know the system they're trying to improve and are trying to get data to study that. And they often run into barriers to get that data, whether it's barriers around being able to see views of data longitudinally, kind of over a lifetime of a patient or over years of a patient. More often we have patients who come to see us at Mayo and we don't know what happened to them before they saw us or what happened to them after they saw us. So we have sometimes gaps in data for our teams that are trying to improve care that we are trying to fill in. And again, having better data for these teams will let them accelerate the pace of improving the value of care that we are able to provide at Mayo Clinic, and then broadly working with partners and collaborators to really improve value of care throughout the U.S. is our goal. And we see Optum Labs as a way to get that data, to accelerate the reliability, the timeliness, the broad base of data that we have to support these teams.
So should we think of this new effort as some sort of Manhattan project, or is this some sort of similar to Bell Labs, similar to the Santa Fe Institute or Microsoft Research?
Well, I think the Manhattan Project may be a little grandiose, and hopefully our interests are perhaps a little more beneficial for mankind. But I think that there are a lot of models that you can think about. AT&T Bell Labs was the one that was thought about at the beginning of Optum Labs because of all the value that it brought to society that was not necessarily directly benefiting AT&T. On the other hand, it's an imperfect description. Xerox PARC is another imperfect description. The IBM Research Institute, I think, is another one that has some aspects of it as well. Even the MIT Media Lab is an example of an organization with collaboration where people come to work on, with particular technologies, et cetera. But the one that appeals to me most is the Large Hadron Collider. For those of you who know physics had reached a point where it really had been stuck. It was impossible to prove whether the Higgs boson existed or not, and what the nature of dark matter was. And in order to do that, it was necessary to build a facility that was far beyond the possibilities of any of the research institutes or physicists that were working on it. And so CERN put together $4.4 billion, which is substantially less than my budget. And they put together this organization which physicists from all over the world come now and collaborate with, and are pushing forward the boundaries of physics through collaboration, through a shared facility. And we'd like to see ourselves in some ways as being that center that organizations can come to work.
Great. So, Paul, you and I have known each other for 7-8 years. You're a longtime entrepreneur, having started Face Forward and been the chief medical officer of Humedica and a couple companies before that. Do you guys expect new companies to ultimately emerge from all of this innovation?
Yeah, we do, I think, and I'll be interested to hear what Mark has to say about this as well. But it is one of the goals, in fact, and it's one of the ways that over time, hopefully, Optum Labs can become self-sustaining. We are concentrating on research at this point. We're beginning a clinical translation program because that's the next step, and we have to sequence this. As everyone who's done a startup knows, you can't just do everything at once. But we definitely have an interest in working with the organizations that come to us in developing technologies and innovations that could be spun off into companies, that could be developed internally within Optum with benefit to our partners, that could incubate or be done in collaboration with venture capitalists in the Boston community or elsewhere. Frankly, we're not really fixed to the Boston community in any way. And we have deep ties in Minneapolis and even in San Francisco, so that the findings and the clinical translation that we identify don't stay stuck in little silos, don't become just a little piece of the puzzle, but actually are distributed widely and become valuable for much more than just just a few organizations. Mark?
Yeah, I would agree, Paul. I think our goal would be to see Optum Labs stay a very clean research environment, but there definitely will be IP that comes out of our work with the labs that will need to be addressed, and we'll likely spin out new methodologies, new tools that will have a place to land somewhere.
Okay. In terms of the limits of data, is this going to be focused on any particular kind of data, like electronic medical records or claims, or will it go all the way to genomics? And ultimately, how far does the science, what are the limits of the science of Optum Labs? Because that kind of name in a place like Kendall Square, Cambridge, evokes a lot of other ideas.
Well, there are no lab benches, and there's no water in the facility other than in the sinks and bathrooms. So this is not a labs in terms of the wet labs that I'm familiar with from my biotech days. But in terms of the limitations of the data, we're focusing on administrative claims data and electronic health record data. Another important data source that we're bringing in is consumer data from some major consumer organizations and other data, which we can link together all, and this is very important, all in a de-identified fashion, rolling up various variables so that the data remains statistically de-identified, but we can begin to look at consumer behaviors in a whole variety of parts of their lives in a de-identified fashion that can allow us to build models because the way that people interact and their consumer interests and the way they buy houses and pay their bills all is very important as to how they interact with the healthcare system. And so understanding that and modeling that will create another dimension at which healthcare data can be looked at. Genomic data is something that's aspirational over time. At a terabyte per person for a genome, you've got to have, if you're going to do anything in bulk, you've got to have a real commitment to it. And right now, genomic data, as far as we're concerned, is PHI, and we're staying away from PHI. But we believe that certain genomic markers, certainly we're ready for at this point. Over time, we'd like to lay genomic data over it, but we're going to do it very carefully with great attention to privacy and also with a compelling interest and need to know.
And I think, the questions that come out of our partnerships and our collaborations will drive us to understand what data we need to bring into the labs. As we understand the hypothesis, the projects that we have will broaden that set of data that we want to get into. And there are gaps in data right now that we understand we need better data. Patient-reported outcomes is one big gap that I think nobody has really found a way to resolve, and to have broad longitudinal data from patients on their health status, their pain status, their ability to function as they'd like to daily. Those are things that should be part of the discussion of what's a high-value delivery system.
So we fast forward, say 3 years from now, 5 years from now, we're back up on stage. What have you guys done?
So if I wanted to paint a scenario, I think we would have a number of papers on an annual basis that will be published in places like Health Affairs and the New England Journal of Medicine, Journal of American Medical Association, et cetera, that would have high impact, that there would be position papers developed from some of these papers on the desks of people who set policy in Washington and in state governments and even international governments to that extent. We would have the results of some clinical translation that we could point to, saying that the particular interventions that we identified or issues we identified when applied directly within a healthcare setting actually yielded results which improved patient care and lowered the cost of care. And we would have some companies that were incubating and or technologies that were being developed that had high promise, and maybe one or two even deployed.
And I'd say, the labs would be seen as a trusted partner, and being able to say what are the best practices to deliver the best, highest value care we can, and have data to support that. And then we've not only have the data, but we've driven that through to actually implementing those best practices as broadly as we can based on that evidence.
And I think, if I can just add one more thing, what we're trying to do is to create a positive feedback loop. You know, we've started with Mayo, and we've started with the Mayo data and the United Healthcare data, which is a very, very unique resource. We have a number of partnerships which are going to be coming online very soon, and those partnerships are going to bring similar kinds of well-known names and organizations and some additional data of high value, and that will create more interest and more interest. And I think an important thing to think about is we really have no competitors. I know there are some organizations that are looking at this from a commercial perspective, et cetera, but we don't think of it from a competitive perspective. In fact, whenever we hear of another organization that's collecting data and trying to link it together, we invite them in. We want other payers to be in. We want everybody to be in this tent, because if it's all in one place, there is the opportunity to dive deep into it. And this is very, very different than efforts I applaud, which are distributed data networks, where the data remains in its various silos but can be queried at a distance, but in which you can't really dive into the data in the same way.
So this sounds really great. These data assets that you're collecting and the sort of the open culture that's being promoted. Let's get practical in terms of how do groups get access to the data? I see Fred Trotter here in the front row, who I'm sure would love to get his hands on all this data, but I'm guessing it's not going to be as easy as to just upload some data to his machine, or he just has to fill out a one-page form. How does Fred get access to this?
Well, so it starts with a one-page form. That leads to a typically 8 to 10 page form after there's been some feedback. We're trying right now to review those on a weekly basis. Anybody can come to us with a project. The project has to fit the Optum Labs mission. It has to be non-commercial. So we are not looking for commercial organizations to get commercial advantage on their products based upon the results of an Optum Lab story. There are lots of other places to go to answer those kind of questions. These should be non-commercial projects. And they have to be reasonably scientifically valid. But they also have to, we are looking to do cost recovery in this. We're looking for our partners to share with us in the cost of this. So we've created a business model where there's a charge for the data. That charge is consistent with the types of monies that an NIH grant would be very willing to fund. And that could be paid for by an NIH grant. It might be paid for by one of the other partners, such as a life sciences company that was interested in a project, or a technology company that's funding, or other venues. For certain partners who come in and commit in a significant way their resources, their data, their technologies, their expertise, we'll do something where we'll bundle up some of those studies and make several of them available at low or no cost. But in the end, this is open. On the other hand, we do need to restrict this so that to having these studies paid for again at NIH levels, so that it is available to everybody, and we don't get overwhelmed with the effort.
And we've taken the first 6 months of the Optum Labs being in existence to set that infrastructure in place with Mayo IT folks working with the Optum Labs IT folks. We have that in place now, and we have a team of researchers at Mayo, a fairly broad team, who are beginning to work with the data around specific research topics. All those have a statement of work. They have a very specific research statement and description that's been laid out. So it's not wide open. It's around specific research agenda topics.
Okay. So is it fair to say that the real mandate for Optum Labs is really about accelerating the generation of evidence of what interventions are working in healthcare, and for what types of patients are they working? Is that
the way I look at this is, and this is informed by my stint at Humedica as chief medical officer. is at the sharp end of the stick. Doctors are taking care of patients in the clinic, and they've got to do the right things. There are population management tools which help them to do the right things and help them manage patients into programs, et cetera. Those are informed by population analytics tools which identify the patients and the physicians that need to go into those population management tools. Those population health analytic tools have to be looking for something longitudinally, and those are defined by the guidelines and the identified gaps in care and the other issues in medicine that derive, in a sense, from comparative effectiveness research and outcomes research. So OptumLab's big field is identifying helping identify newer issues that could be guidance or gaps in care, or reasons for failing to meet guidance or gaps in care. It's that big fuzzy area that turns into guidance that goes right down to the patient. But it's more than just the research about that. We actually want to make sure, and this is an important part for Mayo and for a number of the other partners who we're talking with, to drive that into clinical translation, to make that actually, to watch it actually work and see whether we're doing the right thing before we conclude that that we've got it, if you will.
So let me be a little provocative then, because it looks like comparative effectiveness is really at the core of some of what you're doing. Why not just let PCORI, the government-funded effort, a couple $2 billion have gone into really comparing different treatments in different populations. Why not just let them do it? What's Optum Labs going to do that's different fundamentally than the PCORI effort?
Well, first of all, we're working to collaborate on some of the CDRN grants and in PCORI, and we want to share our data with others who might need that data. There is a lot to do. Just a tremendous amount. We're at I was just at the Comparative Effectiveness Research Conference a couple of weeks ago. We're at the infancy of comparative effectiveness research. We're at the infancy of it being accepted by pharmaceutical companies, by payers, by formulary committees, et cetera. There's a ton of methodology that needs to be worked out in order to make it be the equivalent of clinical trials. And there's a lot of work that can be done that can be approached in the collaborative fashion that we're talking about, bringing life sciences companies and again, consumer companies and others who really aren't necessarily working, and patients who aren't necessarily working in the same way as PCORI, in the same way within the PCORI infrastructure, at working at problems. So we think we're going to work very collaboratively with PCORI, but there'll be lots and lots for everybody to do.
Okay.
And we have a number of PCORI grants, and we work very collaboratively with them. But again, our researchers who have those grants, we'll be looking to Optum Labs as a way to help them have that data for those grants.
So in our last 2 minutes, I'd like to get just 1 minute each from you to really just tell the crowd why this is really going to matter. Why is this going to matter to the average person? Why should they pay attention to this? Let you start with you, Mark.
Sure. So our Center for the Science of Healthcare Delivery was founded at Mayo Clinic to design, study, and implement higher value care delivery models. From our perspective, Optum Labs gives us the opportunity to support that vision of accelerating the pace at which we can change our delivery systems to be higher outcomes, higher safety, higher service at lower cost and lower utilization. And the labs gives us a chance really to demonstrate that through good evidence, good methodology, good partnerships, good collaboration. And we'll do that in a way that hopefully is more efficient instead of all the silos of people trying to do this on their own in their own little data set or their own environment. We can do that collaboratively, which will let us accelerate.
Great. And the commercial organization that is the overall sponsor of this, Optum, has a tagline which some of you may have seen, which is making the system work better. And it's really a passion within the organization. In our little Enclave, which is run in a very, very different way than a commercial organization, we have the same idea, and we believe that by bringing together the many different constituencies that are interested in working on important problems, multimorbidity, the impact of mental illness on the treatment of chronic disease, et cetera, that we have a chance to look at problems and solve problems in a way that works for everybody. And in the end, the public, the people who care about the cost of medicine and about the outcomes of their medical encounters will hopefully will be able to point directly to things that have been developed in Optum Labs that have made their lives better.
Great. I'd like to thank both of you for a great opening panel.
Thank you.
Thank you.